Hello and welcome. Just going live now. I think we're getting out to people. I'm just going to wait probably about 10 or 20 seconds just to make sure people have joined the webinar. I know with these things, it's not like a television program when we sort of know when the person's going to go live. I've gone live, a few people joining, but I'm just going to give maybe give it a minute to make sure we've got enough people joining, and then we'll start this webinar on OCD and hoarding. So that's coming up in just a second, but we'll give a few people a bit more time to join. Okay, I think let's get going, shall we? So welcome to this very special webinar on OCD and hoarding. I'm Sharon Fletcher. I'm a broadcaster here in the UK. I know we have people who will be watching from right around the world. I work on the BBC and ITV and also on Channel 4 here in the UK. Now, this is a webinar that's put on by Orchard, the OCD charity. We are a charity, I'm a trustee of that charity, and we are a charity looking for new ways to treat OCD away from the conventional type of treatment, SSRIs and CBT. So my connection to OCD is that my son has quite extreme OCD. He is in a much better place now, but the OCD has been a real challenge for our family over the years, and that sort of threw me into the world of OCD and into the world of campaigning to raise awareness for OCD, but also joining charities like Orchard in finding new ways to treat it, because there are many people who don't respond to the usual ways of treating OCD. Now, this webinar is being hosted by Made of Millions, so thank you to them. I will be speaking to Dr. Sharon Morein, Associate Professor at Anglia Ruskin University here in the UK. I had a chat with her last week, and she is absolutely fascinating. She's got so much to say on the subject. Before I go to her, I just want to remind you that you can get your questions in. I will be trying to get to as many of those questions as possible and putting them to Dr. Sharon Morein. So this is your chance to quiz a real expert in this area. Get the questions in. I'll ask a load of questions and then I'll come to yours, so I can see what you're writing coming up. Please get them in and we'll try and get around as many of those as possible. Let's see if I can get the technical side of things going and bring in Dr. Sharon Morein. Let's see if I press that button. Here she is. Lovely to see you, Sharon.
Hello. Hi, Sharon.
I actually, for those who are watching, we connected a bit earlier to check the line, and I was just really in awe of your plant decorations behind you. They look really good. I'm very impressed.
Thank you. So all credit to my husband.
You should take the credit. Now, let's get straight into it. So what is hoarding? Because many people have made the links between OCD and hoarding and other situations and conditions that people have. But hoarding it feels like it's quite a new thing. I was reading the other day that it was sort of only, in 2013 when people started to establish that it was a thing that you could sort of monitor and put on a scale and work out that people have. Is that true?
Well, yeah, yes, to a certain degree. So hoarding's always been around. Obviously, you can find cases throughout history. And I think people encounter this even in literature and sort of popular fiction. I think it's how we viewed hoarding that is kind of a new thing, because in a way it was a bit, you can envision it like the ugly duckling of the OCD world. So when we look at things like OCD and hoarding, we look at categorizations. So when you come into clinic, a clinician will sort of assess a person, interview them, figure out what their problems are, and then give them a label and a category. And the way that psychiatry and mental health research works is through these categories. So this person has OCD, this person has ADHD, this person has schizophrenia, maybe this person has OCD and ADHD. And inside hoarding, so one thing to say is whatever we say today, certainly, and in research and probably in the clinic, is we tend to make generalizations that are true for most of the people most of the time. There's always going to be a minority of people where that isn't quite true or it doesn't quite fit. So do take everything that I say kind of with a grain of salt, that it's most of the people most of the time. So going back to OCD, when you went into sort of an OCD clinic, and OCD kind of belonged under this umbrella of anxiety disorders. It's not just the only anxiety disorder, there were many. And OCD in a way was the ugly duckling of the anxiety disorder, where it was kind of fitting, but not quite. There were things that didn't quite fit in it. And under the umbrella of OCD, you had, different things that people complain about and suffer from, be it, ordering. So I hope nobody's sort of too upset about the fact that this isn't symmetrical behind me. But, you have checking, cleaning compulsions. There's different flavors and types of complaints that different people will have. And one of them, at least as OCD was conceived, was hoarding. So it kind of came under the umbrella of OCD, but it didn't quite fit. So people who had hoarding, you'd expect to see them in an OCD clinic, or clinicians who deal with the types of problems people with OCD deal with. And so there you would see people with hoarding. But over the years, there kept being a bit more sort of gradual accumulation of this sentiment that hoarding doesn't fit to such a degree that actually it's its own thing. And again, it's kind of a gradual realization as well, even that most of the people that have hoarding don't actually have the key ingredient, so to speak, that people with OCD have, and that is time-consuming, distressing obsessions and time-consuming, distressing compulsions that interfere with their everyday life. So we have things like the Y box, the sort of a scale that we interview people with OCD to see how bad the OCD symptoms really are at that given point. And, just roughly speaking, it's a scale that goes from 0 to 40. Anything above 12, you're kind of really suffering from OCD or having, significant impact on your life, really. We sort of, sometimes in research, we take 16 and above, but 12 and above, you've definitely got something going on. And you can look at some of the people with very, very severe hoarding, and they would have a value of 2. They don't have compulsions. They don't have obsessions. So how do they fit in? I mean, they're not getting captured by these really key symptoms of OCD.
That's so surprising. So we're saying that, hoarding, if you say that, then it sounds like hoarding is something completely different to OCD. It just happens that they seem to, by chance, overlap at times.
Yeah, so when the research actually happened, when people went into an OCD clinic and said, okay, well, how many people really have, the cardinal symptoms of hoarding, and we'll probably get to what those are in a second, it was about 20%. So, that's a minority. It's a significant minority, but it's still not most of the people. Now, that's not to say that there were, of the remaining 80%, other people didn't have hoarding symptoms. It's just that they didn't fit a quite high bar, in the sense, the threshold to tip you over into having the actual full-blown condition. And the same with hoarding is that, when you go into a group with hoarding per se, and you start looking at what they have, it's about, 20% probably have OCD, or maybe 30. So there's definite overlap, but it's not that simple.
So you can't say someone who is a hoarder has OCD, and you can't say someone who has OCD is a hoarder, but there is a higher chance that you will have one and the other.
Absolutely. So there is.
If you had neither, yeah, I see. So tell me, what are the key things, the key components to someone who has hoarding? What? I mean, I keep things, but I wouldn't call myself a hoarder. When do you know that it's a problem and it is actually hoarding? Is it because it's a disability and it starts to get in the way of your life?
Yes. So one of the things that of how we've changed over the years is how we view mental health conditions. And I think back in the olden days, I don't know, before I was born, let's say, when we were all young and pretty, there was sort of a more categorical approach where we kind of had, the subset of individuals who had a mental health condition, and they were kind of over here, and then everybody else was normal and they were over there. And it was kind of a black or white, either you have it or you don't have it. And we kind of know that's probably not a good view, or not a realistic view, of many mental health conditions, including OCD and including hoarding. And we now take a more dimensional approach. And by dimension, you can think continuum. So it's not just a continuum on one dimension where, hoarding, we either have hoarding and, there's a continuum where there's lots of hoarding on one end and no hoarding on the other, and everyone's in between. It's actually even the facets of hoarding, which we can break down. So one thing is clutter. And so you can imagine, some person has a lot of clutter in their lives, And some people have very minimalistic houses. And even that you can break down, it's a bit more complex. But clutter is a massive component in hoarding. Another one is difficulty discarding. So we're talking about possessions, and I use the word possessions in the loosest sense of the word. You know, for some people it can be paper, for some people it can be, again, you name it. You know, we've found people to hoard any manner of objects, and even, you know, digital possessions is a thing. So in a way, you've got lots and lots of possessions, and people with hoarding issues, they have the clutter. Second, they have difficulty discarding. So many of us, and I'm sure you as well, Sean, have sort of kept on to something because you might need it. You know, you may reflect 2 years down the road that actually you've never needed it, but, you know, you like it being there. And so that sentiment is part of the reason why people have difficulty discarding. There's additional aspects to it. One being, for example, emotional attachment. So again, we can reflect that it's a dimensional thing. You know, many people who have not a shred of hoarding characteristics will still resonate. You know, maybe you have something that you've kept since your childhood for sentimental reasons, maybe, you know, from your children. You know, it's something that will bring back memories, you know, so there's an emotional component there. Taking place. So people have difficulties discarding for many, many, many different reasons. But the bottom line is somebody who hoards will have a lot of clutter in their house. And when we say clutter, it's to the level where the living areas are not, you can't use them for what they're supposed to be. So if you have, you know, a garage that you never use and there's a lot of clutter in there, that's one thing. But we're really talking about, can you use your bathroom as it should be? Can you use your kitchen surfaces? Is your living room a place where, you know, you can sit and entertain people or watch television or carry out, you know, any hobbies that you usually have? Whatever you do in your living room, can you use it for that purpose? Your bedroom, can you sleep in your bed, for example? So that's what we mean when we talk about clutter and difficulty discarding. A third component is accumulation. Not everybody, this one's a bit more controversial kind of it. So it's in the criteria, it's something that we acknowledge, but it's a bit more debatable, and that's excessive accumulation. So if you go out and you come home with too much stuff. So that one's, again, very, very, very common, very much part of the condition, but a little bit more controversial than the other two.
So that you might go out shopping and, you know, if you've got lots of money, you buy lots of clothes, and you buy way too many, you don't need all the clothes. Could that be classified as hoarding?
Well, it relates to something called impulsive buying.
Okay.
That's where a bit of the controversy comes in. And again, it's that debate of trying to fit everything into neat boxes where either you have this or you have that. And that there are shared characteristics between the two. So in the literature on hoarding, some people have looked at impulsive buying or how do you fit exactly excessive accumulation. And excessive, again, it's a vague term. We want, if you're looking for exact, nice, you know, beyond this number, you will have this, and below this number, you won't have it. There's no clear threshold there again. And Sean, you rightly picked up on this issue of impact. So when does it tip over into a full-blown condition? And generally speaking, it's true for OCD, it's true for other mental health conditions. It's the issue of distress and impact. So does it impair your life? Is your life less because you have this condition in it? So if I were to magically take this condition and, you know, make it like you never had it, will your life be so much better? And it can impact can you work? It can impact your social functioning. So, you know, if your hobbies, who you want to be and how you want to be. And again, it's an issue of degree. So we can all use a bit of improvement, but here we're talking significant impact. You know, you're not holding down a job because of the condition. So that's one aspect. And when we talk about impact, the other is distress. So how distressed are you really? You know, obviously, the more distressed you are, it's going to have an impact on you, and that sort of tips it over.
Yeah, you mentioned the Y score for OCD. So that's a self-assessment. But it is actually quite accurate, isn't it? Because isn't it someone says a score what their OCD is, and then 2 weeks later they do the same. So that's why it's quite accurate, because you're the same person giving the same assessment.
Yeah.
Is that fair to say? And also onto that, how do you monitor hoarding? Is there something similar, or is it a clinician coming into your house and saying, you've got loads of stuff around here, you have hoarding issues? Sorry, about three questions there.
That's 2 questions, and that's 2 really, really good questions. So one thing is the why box actually. So one of the things that is interesting about the world of OCD in terms of research is that in different areas, they often have different scales, different questionnaires, different interviews. And the OCD has been very sort of good in using one thing. So it's when you look at different studies, they almost always will have a Y box score to characterize the, just how bad the symptoms are for the patients in that group. And it means it's comparable. So we can look at study 1, study 2, and we can say, okay, they had about the same severity. So the Y box is actually a questionnaire. So it's a clinician administered questionnaire or research administered, and there's a bit of training to do it. It's 10 questions, 5 on compulsions, 5 on obsessions. It's actually clinician rated. So there is a self-report version that some people can run through themselves. But ultimately, the one that we use in research is interview based, and that kind of circles to this issue of insight, which is, people have a good handle on what they're experiencing. Obviously, the entirety of mental health often focuses on you come into the clinic and you tell somebody. So your self-report is the critical window and lens through which you characterize somebody. But there is value in having an extra sort of slightly objective experienced pair of eyes, because when people self-report, first of all, there's this issue of insight, which specifically for hoarding is a big deal. And that is, do I really have insight to just how bad things are? And it can tilt both ways. So with OCD, actually, we often have the opposite, and that is that people think, no, that's not entirely true. Some people think that their condition is worse off. For example, if you have OCD and depression, and we know depression is a big deal in people with OCD, so about 1/3 at any given moment will have it, and 2/3 will have it throughout their lifetime. So we know that if you just ask somebody with depression how their OCD symptoms are, they will tend to report them as worse off. And it's a normal kind of reaction. Having depression means the world kind of looks that much worse to you. And that will be reflected through what you're saying. And then it takes a clinician's eye to actually be able to discount what parts of what you're experiencing are because of the OCD and what parts are because of the depression. So that's why interview assessments are a bit valued, but it does assume to a degree that you have some insight. So circling back after all that to your question about hoarding, there has been a sort of gold standard self-report questionnaire that is very, very commonly used, called the Savings Inventory Revised. You can Google it, it will come up. It's 23 self-report questions, and they generally look at things like clutter, difficulty discarding, and accumulation. So everybody's welcome to Google it and have a look. It's not diagnostic in the sense that if you score high on it, it doesn't necessarily mean you have hoarding, but hoarders will, or people with hoarding will score high on it. So you've got to just be careful there. And of course, it can be flavored by, if you have depression or OCD, it will tend to cause people to endorse and think things are that much worse than they really are for that particular symptom dimension. Having said that, there's since 2013. So the big year was 2013, because up until then, hoarding was under the umbrella of OCD. So somebody could have really, really severe hoarding, very little components of obsessions and compulsions, and they would still get diagnosed as OCD. Come 2013, the book that categorizes things, we call that the DSM, sort of got revised, and OCD came out of the anxieties and became its own category. So it kind of is now its own umbrella.
It's not an anxiety disorder.
It's still, well, obviously it's still got anxiety components to it. So the fact that people have changed the categories doesn't mean people experience it any differently.
Yeah, I see.
So it's always going to have that. And there was a reason it was under the anxiety umbrella to begin with. But remember, it didn't quite fit in there. So now they've kind of decided it so didn't fit in there that it merits its own umbrella category. So it's in the OC and related disorders, with number one being obviously OCD under there. But there's additional conditions under there that it was felt that fit better in this category versus where they were before. So things like body dysmorphic disorder existed before, but now it's under that category. Hoarding didn't exist as a hoarding disorder. There wasn't such a thing. You couldn't go around saying, I've been diagnosed with hoarding disorder before 2013. I mean, you could, but, you know, clinicians would be like, oh, well, actually, there isn't, you know. So again, getting caught up with the categories that they use and the labels that they use. From 2013, there was now very clear criteria that if you have this, this, and this, and, you know, this happens to you, you have this label. You can say, I have hoarding disorder.
2013, I mean, that seems so late, doesn't it? I mean, that,
yeah,
you know, there must have been, I mean, people have been hoarding, people have had mental health issues since people have been here. And surely people have been hoarding for however long people have been here. So to make that 2013, I mean, that's not even 10 years ago. Yeah. It seems,
so
seems
again,
crazy.
There has been research. I mean, it's not that, you know, we weren't aware of it, that clinicians weren't aware of this thing. Absolutely. But it was under this umbrella. And this is where the importance of categories comes in and how they influence our lives. Sort of, you know, we have a tendency as human beings to like to categorize things. I mean, think of, you know, Darwin. One of his great values is the fact that, you know, we're making order in the disorder and mess that is reality as we see it, right? We need to make order and sort of categorize things. The problem is when we do those categories, they're really, really useful. So from a clinical perspective, it's incredibly useful. But at the end of the day, one single person can have more than, you know, can fall into more than one category, and it's an issue of sort of mix and match and flavors, because you can have a person with some of this and a lot of the other, and it doesn't quite fit exactly into the nice squares that we have. So there has been research on hoarding, but it sort of had a gradual transition of accumulating that evidence to make a case, to change things.
Which leads me on to my next question. And it's one of the things we talked about the most when we spoke last week is these categories. So as you say, people like to categorize. And what you've done in your recent research is you've sort of bridged some of those categories, and you've in particular ADHD and hoarding. You've talked about OCD and hoarding and the links, but there are links in other ways. And sorry, I'm throwing in about 5 questions each time I ask you something, but I can imagine in academia, you have people who are sort of very good in their own field, head down, this is what I'm looking at. And they probably don't have time to look up and say, well, what else is around me? Oh, there are links with that and this. They just do their own thing. Is that fair to say? And can you talk to us a bit about your research?
Yeah, so absolutely. I mean, there's so much information about OCD that just to wrap your head around it, and OCD is complicated. Let's, you know, no two ways about it. There's different flavor, like I keep using the word flavor, but, you know, it's just a way to try and convey, you know, there's different aspects to OCD. There's different dimensions. You know, you can have 2 people with OCD that don't even overlap in their main complaints. Like, yes, this person is going to have compulsions and obsessions, but they're going to be completely different from that person. And the problems that bring somebody to the clinic can be completely different. So on the one hand, there's a need to really, really understand, you know, one condition. So you spend all this time sort of, you know, drilling down and figuring it out. And yes, you can look sideways. So people with OCD, as I mentioned, have depression. Certainly some of them have hoarding. And so those would be kind of the conditions that you would branch into and see how they overlap, you know, look at the overlap between the obvious ones. And just to circle back to hoarding, so again, it's this evolution of understanding hoarding. One thing, just because, like, again, completeness, you asked about how do we measure it, and I said, okay, we use the savings inventory. There's a couple of other things. There's a self-report questionnaire on OCD that had a hoarding subscale, because again, historically, it made sense to do that. There's the clutter inventory, which is actually pictures of just cluttered spaces increasingly being cluttered. And again, you can Google it and find it. There are some interviews, sort of interview-based tools that came out very, very recently. So kind of after 2013. So in a way, the 2013 change has also instigated more research, because now that there's a category with a label, now we can look at it a bit more systematically and we all agree on what it is. which is, again, another important thing, is that we all need to agree on definitions. Otherwise, deaf people talking, not really listening to each other. And thinking about people with hoarding, there's a lot of curiosities, I would say, or sort of, it's an interesting entity. So we talked about the cardinal symptoms, and we talked about the emotional aspect. But when you go looking for people who hoard, you either find them in an OCD, or used to find them in an OCD clinic or an anxiety clinic, because that's where they get shifted through the healthcare system. You can also look to patient groups. So people who say, I have a problem with hoarding, so I'm going to look for a support group, I'm going to look for a relevant charity, and they kind of get together and they have a voice together. The final place where you can encounter people who hoard is through sort of what we in England call, or the UK call, councils. So sort of, your, the people who manage the houses and that kind of thing. And that's where you get, unfortunately, some people who hoard, it gets to be really bad, and then it becomes health and safety issues. So it becomes a fire hazard. It can become a rodent problem, or insects. So you have infestations, the neighbors complain, family members will complain. And that's how they kind of come forward, not because they think they have a problem and they're seeking help, but because other people sort of push them into it. And sort of these are our sources of information of what we would know about the problems of hoarding. And to be honest, when you're looking at the hoarding research, what do we have to go on? One of the problems is that you get, when you're talking to people who hoard, they tend to be older. Sort of, you don't see really it's rare to see 20-year-old people walking around saying, I'm a hoarder, I've got problems, or what have you. It's more older individuals. When I mean older, I mean sort of late 50s, 60s, when it's quite sort of later, sort of late adulthood, if we're going to say that. And that's when you talk to them, they don't say they developed it later in life. There is actually in dementia one aspect where you can develop hoarding symptoms later in life, but we're not talking about that more or less today. Today, we're talking about people who have hoarding disorder as a mental health condition. And when you talk to people, they don't actually say that it evolved later in life. They say often it's like my teens, my early 20s, that's when it started. And then you're thinking like, well, hang on a sec. If it started, 30, 40 years ago, why is it coming out now? And sometimes one component is it takes time. So, it's kind of a gradually evolving problem. But then they point to actually it happened back then, but now I'm in a place where I'm seeking help for it. So that's one thing.
So when they're 18, they were hoarding the same as when they're 60, but
the tendencies, really? Right? The tendencies, they had that excessive accumulation. They had a tendency to have clutter in their house. They had the difficulty discarding, but for various reasons, when you're 18 or 20, your control over your physical environment is often more limited than when you're 50 or 40. People tend to be a bit more affluent and have more control. We don't entirely know what goes on in people's 20s and 30s when they later reflect on the fact that they always had the problem, because you're relying on people reflecting back on what was a decade or two ago. Now, unfortunately, both you and me, we can reflect on what was, what happened as adults a decade or two ago. So we're old enough for that. And that's pretty challenging. Like, we have our memories and stuff, but, you were on TV, you can actually document it. But most people, we don't have an exact record of what we were like and what our lives were like 20 years ago. We have our memories. So that's one aspect. And the other thing that's kind of puzzling in the research is most of the people in support groups, again, not all by far, but there's definitely a female majority. So we're talking more than half identify as women. And there is another piece of research where you don't actually look at hoarding per se, but you can do sort of these large scale, very superficial studies where you just ask one question about all manner of conditions. And when you look at that kind of research, it looks like it's 50-50. So we know, for example, in OCD that it's about 50-50 in terms of gender. And yes, there are differences between the genders in terms of when the condition develops and how it can manifest, but roughly it's the same. Now, we have other conditions, mental health conditions, where it's not 50-50. There is things like autism where it's predominantly male. So again, they're definitely females, but it's not 50-50 probably. And then we have things like depression where up until now, it was more tending towards females. So for hoarding, the evidence suggested that it was roughly 50-50, but when you go into clinics, you go into support groups and talk to patients, it doesn't look like that. And then the question is, well, what happened to all these people, when they were younger, and where are all the men?
And is that because men just don't self-diagnose, and
it could be, but it seemed to be something more going on. And that's where this issue of insight comes in. So insight is a really important aspect of different mental health conditions, but particularly so in hoarding. And that is this issue where, as I mentioned, some people come forward and say, I have a problem, but others don't think they have a problem. Or they'll identify OCD as having their problem, but not really talking about, they may also have hoarding. But when they go into the clinic, they talk about their OCD and then they don't say anything about their hoarding. And I've actually met patients like that, which the hoarding symptoms kind of they happen to mention them by accident in passing without really realizing that, they should have been telling the clinician about that as well. So that's kind of a bit of a reason why this research kind of happened. And that is trying to figure out where that gap is. And a massive hint, so to speak, is this issue of inattention. And this is kind of speaks to your observation about, people drilling down too much into one condition and not another. And myself as a researcher, I just happened to sort of do some research in OCD. I'm interested in hoarding, but I also happen to do research in other mental health conditions, one of which is ADHD. And in the hoarding literature, sort of, when there's conferences and scientists and clinicians talk about hoarding, there's a link with something called inattention. And again, it comes from the patients who again, tend to be older and sort of reflect back on what their problems throughout life have been. And many of them say, well, we have this problem of inattention. And by inattention, I kind of mean, again, umbrella term that roughly talks about concentrating, but also being forgetful, having difficulties planning, organizing. So it's sort of a family of overlapping, kind of closely related abilities, so to speak. And psychologists often call these executive functions. But inattention is kind of tapping into a lot of these aspects. And I think anecdotally, a lot of hoarding individuals, people with hoarding kind of say, I think I have undiagnosed ADHD for all of my life, with inattention being sort of the main complaint. And this is kind of established in the hoarding literature. So people know that, inattention is a thing in hoarding. But obviously there's another place where inattention is a big deal, and that's in the ADHD literature. So literally, attention deficit hyperactivity disorder, it's in the name. And there, curiously, hoarding isn't a thing at all. Not mentioned at all in clinics. So you can have
not in the literature, but it is anecdotally in patients.
A little bit in patients, as much as you happen to canvass 200 people with ADHD, a few of them are going to have comorbid conditions. So you're going to find, a handful with hoarding just by chance, because if you take any 200 people, you're going to find a certain proportion with hoarding. But there's not really that link. So you remember we were saying that in OCD, you get these 20% hoarding. So that's kind of suggesting a link over and above what's going on in the population. And that wasn't really apparent at all in the ADHD literature. So on the one hand, you've got these people with hoarding that have ADHD-like symptoms, and again, that was verified in research. So somebody has followed up and said, okay, actually, they're not just saying it, they actually do have problems objectively. But the question is, okay, then what about the people with ADHD? Do they have hoarding? Yes or no? We don't know. So that's never actually been looked at, other than one study that they asked a few parents of children with ADHD what they thought in terms of the hoarding of their, offspring. And they did suggest that there was some level there. But, obviously one study is limited. One study in the parents of people talking about children is limited. So that's where this piece of research came in. And that was going into an ADHD clinic with adults who have ADHD. They've been diagnosed, objectively through the clinic. They've been getting treatment for it. They've sought help for it. So it's obviously by definition something that is impacting their lives. Again, that issue of mental health, it needs to be significant enough to have a real impairing aspect to your life. So we went in there and we started asking about hoarding. And so we found it.
And you found that link. You found there was a link in the same way that there is between OCD and hoarding.
I think it's too early to say. So again, it's just it's the first piece of evidence going into adult ADHD and actually asking them consistently exactly what kind of symptoms they have. So it was self-report in the sense that we didn't have the resources to go and interview each one.
But I suppose the key is that it hasn't been looked into, and you're maybe unearthing something that we, with more research, will become more apparent.
Absolutely. I mean, for this piece of research, we did kind of cross-reference multiple questionnaires. So, when I said that there wasn't just one way to look at hoarding, there were multiple different questionnaires out there. So we used as many as we could. We used multiple questionnaires for ADHD, looking at the clinic data. So out of all the patients in the clinic that agreed to do the study, one did actually have a hoarding disorder diagnosis. So, we looked at what people had reported they had on the books. So, who had what conditions already. But we also went out and asked people exactly, how bad are things? And there we got up to 20% in a kind of very cross-referencing multiple questionnaires and using thresholds other people established.
Yeah.
So it was kind of high.
It's a real initial research, but it's high in the same way that the link between OCD and hoarding is. So, I mean, we're having a research chat. You're not a clinician, but you can still give just as much a huge amount of insight to someone who, say, is watching this, who thinks maybe that's me. That clutter sounds familiar, or the tendencies to have clutter and the feeling of, I guess, the usual anxiety when the clutter is removed and things like that. Someone watching might feel that. What would you advise them to do? Should they be getting a diagnosis? Where should they be going? Is it the OCD clinic, or is it be focusing on hoarding? What would you say?
Well, first of all, in that sense, I would say information is power. So there's, we talk in the clinical world, there's a concept called psychoeducation, and that is learning about something gives you the tools to process it and understand it better, be it for yourself or for, a loved one or somebody that you're sharing your life with. So go forth and learn is always a good thing. So it could be, there's lots of resources, at least from the UK perspective. There's mental health charities where you can just go online and they've got resources. They've also got contact information if you're feeling distress or you need advice. In the United States, there's the IOCDF, again, massive charity with lots and lots and lots of information and resources. So in the first instance, that's an easy one where you can just, from the comfort of your own home, get more information and get links. In the UK, if you feel that it merits, again, it's crossing into that threshold where, your life is that much worse for it and you're struggling and it's preventing you from leading the life that you'd like to lead. Go talk to your GP. That's also an entrance place. There's the IAPS, improving access to psychological services. Often you can self-refer there. They may be able also to provide some direction. So there's plenty to be done if you recognize that you have it yourself. There's a lot of online patient support, forums and so forth, where you can exchange and learn what has worked for other people. There's self-help books. So things like Buried in Treasure is a very popular one. which was developed by researchers / clinicians that specialize in hoarding. And there's increasingly add-on books or additional follow-up books, because as we said, things that could work for most of the people most of the time don't work for everybody all of the time. So there's still much to be done.
I mentioned at the top of the webinar that with OCD, the go-to is CBT and SSRI medication. Is there a go-to for hoarding, or is it sort of whatever you present with it's sort of a tailored therapy or treatment for that?
Well, that one's a tricky one. So one of the reasons OCD in the OCD world, again, historically, if you go into a clinic 15, 20 years ago, and kind of hoarding didn't fit in, one of them was the treatment issue, where somebody with hoarding, you'd go, they're not going to respond to the SSRIs quite the same way that we expect. They're not going to respond to the CBT quite the way we expect. Now, part of that is it's the ugly duckling syndrome, where they didn't have OCD and you're giving them CBT for OCD. So, of course, it's not going to be ideal for them. Yeah. So I think with this turning point, this is why labels matter. With this turning point, you can imagine sort of the machinery of research sort of slowly, shifting, sort of aligning itself, saying, okay, now that we recognize what's going on, we can put things in place. So encouragingly, there are slowly more and more new initiatives. So there is CBT specifically tailored for people who have hoarding issues. As I mentioned, buried in treasures. There's initiatives like Clutter Buddies, where again, it's a peer support aspect. There's a lot of new things coming out. And we need more research, because that will reveal what can work for what doesn't work for most of the people most of the time. And I don't think it's even at the stage of most of the people most of the time for hoarding. So medication does work sometimes. And again, you have to remember that a lot of people will not just have one thing. So you will have somebody who just has hoarding disorder, and then, obviously you want to treat them for their hoarding disorder. But you have a lot of people who have hoarding and depression, hoarding and alcohol, substance abuse. You have hoarding and ADHD, hoarding and OCD. So it's a bit more complicated there in terms of treatment.
Yeah. I mean, that brings us right back to the categorization. So as humans, we like to say you've got OCD, or you've got depression, or you've got ADHD, or you've got hoarding. And actually you might have all of those or some of them. There is a reason why we do that, though, isn't there? Because if you have a label, I mean, that doesn't sound so good, but if you have a diagnosis, that's probably the best word. It's sort of powerful, isn't it? You mentioned that knowledge is power. So it's better to have a diagnosis than none, because you're thinking, well, I could have all of them, isn't it?
Yeah, absolutely. Again, it's one of those things for all of the people all of the time. I think for many people, especially if they've had a condition or a mental health condition for years without fully understanding what it means, or that they had that particular aspect of, then it is power. It can be very liberating to know, I'm not crazy, I'm not unique, it's not just me. Actually, there's a whole raft, there's a whole community of people that have problems that are very similar to mine, and I can tap into that. And that can be very empowering. That's one reason why people go to support groups and share their stories and hear other people's stories. Having said that, that's not necessarily empowering for everyone all the time. There are people that may resent being given a label. They may not find it helpful. But generally speaking, yes, having that label is sort of a window into self-knowledge or self-empowerment, or we'd like to think that that's the case.
Well, when we were talking earlier last week, we talked about how in research, you're in the research world and not the clinician. You're not a clinician, you're a researcher. So in the research world, in the past, you may not have used patients or had patients involved in that. As clinicians are, of course, on the front line dealing with patients all the time. But that's very different now, isn't it? So when you're doing research, you're dealing with patients all the time. Yeah.
So again, there's this to put generalizations. A lot of clinicians do research, and a lot of researchers attend clinics. So for example, just taking myself, I sat in a clinic for a year and a half, an OCD clinic. So I'm not a clinician, but I knew the patients, I knew their stories. I saw the same patients come in, after a few months and then after a few months again. So you see patterns, you hear stories, and as well, doing research with patients, you chat, you talk, they tell you things, you ask things. So one of the reasons as a researcher, I'm curious, I want to know. So obviously whoever wants to tell me stuff, I'm interested in hearing. So there is that two-way street. There always has been, I think, a two-way street for many, many researchers, and patients did have the opportunity to be heard. But I think especially in the last decade, and some of it is, for example, in the hoarding research, this shift with the new label, so to speak, but also with social media and the way things have changed, the patients have much more of a voice. They come together, they can compare notes. And, I mentioned long COVID as an example of this. If it was pre-internet days, then you get somebody here experiencing long COVID and somebody there, and it would trickle gradually into the clinic, but you'd never know just how big and how consistent the scope of this is. But now we have social media, and immediately everyone can come together, compare notes, and very rapidly it became a thing because you had that power, you had that sort of ability to exchange information. And I think exchanging information is the kind of key term here when it comes to research, where if I'm trying to understand a condition, doesn't matter what it is, let's say it's OCD or hoarding, who am I to discount sources of information? If I don't have the luxury to say, I'm only going to look at, I don't know, brain structure. And yes, brain structure is relevant, but that's just one drop in the bucket of there's so many different sources of information, and patient voice is obviously a massive one of those. Who better to know the experience of having the symptoms than the patients themselves? So in that sense, there's been I think an evolution in how research and researchers, but to think of just how research is being conducted, where it's oftentimes, not always, but it can be really powerful to think of it as a partnership, where what needs to be studied and how it can be studied and how it can be studied effectively can be informed by the people who have the condition that is being studied. Does that make sense?
Yeah. Why have you got involved in this? I mean, why in particular hoarding and ADHD and OCD? What's the sort of the spark that made you want to do more research into this area?
So yeah, I mean, my story is a bit of a windy one, but then I think a lot of times when you ask people about their careers or how they got where they got, they never intended to get there. They just happened to sort of wind around. And so I happened to look into something called response inhibition, which was sort of, I didn't do research on mental health. I did research in psychology and sort of cognitive neuroscience. But for various reasons, response inhibition was a thing in ADHD. So I kind of stumbled into the world of ADHD from that perspective. But of course, ADHD is a broad, huge thing where response inhibition is just one aspect, one small aspect of it.
What's response inhibition?
So that's, again, it's conceptualized as sort of the ability to inhibit your actions volitionally. So when I want to stop myself from doing something, and then therefore I can control my actions. You can see how this is related to something like impulsivity, which is, again, part of the ADHD aspects here, where, they don't. Also, many of them have difficulties, they do something and then in hindsight it was like, well, wish I could have stopped myself there and controlled myself a bit better. But it's also relevant, and this is where I didn't know when I started out, it's also relevant to compulsivity in a different way, where again, you have difficulties controlling your actions, slightly different. Now it's often terminating your actions, or you start out doing something and then wouldn't it be perfect if you just stopped, but you can't stop. So it's that difficulty in stopping from a slightly different perspective. And, where does it overlap? How does it fit? And again, you're back to trying to categorize and realizing that the world is much more complicated than you could ever envision. You get stuck in research, 20 years go by and you're like, what have I added to the world? Or at least I understand it a bit better. I understand how complicated it is a bit better.
Yeah. So you studied neuroscience, and then and that sort of led you onto this area. But so that got you into ADHD. But then, why have you got an interest in hoarding?
So again, it's I think sometimes curiosity, And it's when you learn about a topic or an area of research, sometimes you start to see the holes, the missing bits, which I think I've kind of talked about, where there's a whole area and people are discussing stuff. And especially when, from my perspective, because I sort of dabble in different conditions. So, you know, I know quite a bit about different conditions, but I also sort of look at the similarities and differences there. And so, yeah, it's that idea of crossing over. Sorry, I forgot your question now.
Why? So you were ADHD, but why are you making? How did you make the link to hoarding?
I think first of all, it was through compulsivity and that idea. So I came to Cambridge to look at compulsivity. So I worked with Professor Trevor Robbins on sort of a large scale project there. And when you go into sort of, as I said, OCD clinics, and you look at the OCD literature and you talk to OCD patients, clinicians, you can see kind of that the hoarding, that there was some aspects missing there. So I started to look at that. And then, yeah, you talk to people. So this study specifically came about because, you know, I was sitting at the end of a conference with some people who do OCD, and I was like, but this inattention thing, you know, obviously if it works, if it's a link, then what about the other direction? What about the other populations? It makes sense, and somebody should look into this. And, you know, they all looked at me kind of like, you know, I don't want to do it. And I was like, well, okay, I'll do it. So
yeah, I mean, when I look, and I think this is probably the same in America, but when you look at media coverage, television, of people with OCD, it can be really stereotyped and quite derogatory, and almost look at them, you know, the stereotypes of OCD. And it's not helpful, you know. So there are certain programs in Britain, and as I say, I'm sure they're probably the same in America, you know, extreme cleaners, you know, puts people with OCD in boxes. And I would say there's probably a similar perception of people who hoard. It's the perception is not helpful, is it? There are people who are really struggling, and yet they're, I suppose, just the very nature of it. If you simplify it, it's something that people can laugh at and sort of say, "Oh, look at them; they're messy, or they're this, and I'm not that." Would you say that happens, and that's not very helpful?
Again, it's probably true for every mental health condition that people oversimplify, and they sort of, you know, make generalizations, and ultimately, you know, as human beings, you know, we don't fit in boxes, and each one of us is different. And, you know, in research, we run up across that very quickly because we try to make generalizations. And as I said, you know, if we're lucky, we can say something that's true for most people most of the time, but it's complicated. And yeah, so anyone who has a mental health condition will testify it's not a simple thing. It's complicated. It's complicated to experience it. It's complicated for the people around often. So it's a whole network of complication. And I don't know, because from my perspective, I see the dimensionality of everything, you know. So we talk about clutter. It's, yes, you have people who have no clutter in their lives, but usually they've paid a lot of attention to removing the clutter from their lives. It's still, you're somewhere along that continuum. It's still relevant for everyone. So when I see aspects of mental health, I see the commonalities across people rather than the differences. Sort of, I see everything along a continuum. So I think it's again, knowledge is power. If you can see that we're all shades of grey, there's no black or white, then it's easier to see, you know, the differences among us as just small gradations in that.
And if you're hoarding, so you talk about the clutter. So I'm, you know, in my room, imagine here that there's a lot of clutter around. Is it similar to an anxiety disorder in the sense that if you take away the clutter, you get anxious because you're protecting those things? That's sort of the crux of it, is it?
Yeah, I mean, one thing I do want to say is that it comes up across it a lot is this difference between collecting and clutter. So a lot of people will say, well, I have a collection and I don't find it very distressing. You're right. But a collection is a different thing than a clutter. Collections tend to be organized. They have some kind of logic to them. You know, it could be your personal logic, but when you tend to tell somebody else the logic, other people can objectively say, yeah, that makes sense. That, it follows certain themes. They tend to bring joy or some kind of interest. They occupy you in a good way. Sometimes, very rarely, collections can become obsessions. So there is a little bit of overlap on the edges, but for the most part, they're not. Clutter, on the other hand, is generally a mess, sort of, and it's, and it is that idea that it takes the good parts or the things that could be good in your life out or reduces them. And it's not easy to get rid of clutter. Some people think, oh, well, if you just come in, you go on way for 2 days, we'll clear your house out, and that will be the end of the hoarding. And it's like, not at all. This is a chronic condition. It's that would lead to immense distress. I mean, I wouldn't advise that ever. It needs to be done in consultation with the person. And here comes the circling of why it's so difficult, is often the insight part, and recognizing that you have a problem with the clutter and the hoarding in general in the first place. And so many people with hoarding they recognize that they do have a problem, and they try to do something about it. And it's such an uphill struggle for them. It's a process. And that's where existing treatments can help to a degree. And hopefully there will be new treatments that can help to a greater degree for more people and, make it more feasible. So yes, getting rid of clutter is difficult. I mean, I use the word difficulty discarding, but under that word difficult, there's a lot of human angst and experience there. It's not just difficult. It can be agonizing.
So making that difference between the collection and clutter, you might have a collection of little trinkets or something, and actually you've got hundreds of them, and they've along the mantelpiece or whatever. That isn't necessarily hoarding, but
it's not taking up your space. Remember, we said you couldn't.
Yes,
if you can't go into your living room, and you can't sit on your sofa, and you can't watch telly if that's what you want to do in your living room, because there are so many trinkets there.
Yeah, that's a problem. I see. Gosh, yeah, and often it just becomes a mess. That's basically, it becomes a mess that disrupts, that becomes a disability in a way. It disrupts your life so much so that you can't live your normal life.
Yeah, that's pretty much it. And again, we haven't touched really on this. I mean, we talked a bit about the insight, that there's a whole aspect here of emotion that's wrapped in hoarding. And it's not at all clear that, the people who hoard and have ADHD and the people who hoard and have OCD, are they the same kind of hoarding? It might be slightly different. It might overlap. We don't know yet. So that's an important component to it. So for example, when you organize, you have in ADHD, you'll have aspects where it's difficult to organize. And you can see how that feeds in. In OCD, there's emotional elements and trauma often that can kind of tip the balances, make things that much worse. And there's probably lots of overlap with ADHD in that sense, that it's also got an emotional component, and there may be overlap with people with OCD having a disorganizational component. We don't know yet. There's so much to discover there.
Yeah. So much to discover. And I guess if we have this conversation in 10 years' time, the research that you'll have done, the research that other people will have done, feeding into or following on from what you've done, things may have changed in terms of views may have changed, and we will know so much more about it. So it's a very exciting area. And I guess if you are struggling with hoarding, an incredibly exciting area, because it's an area that just probably hasn't been looked into enough. So it's absolutely fascinating talking to you. I'm looking at the clock because I know we've literally got a couple of minutes, so we probably should actually wrap things up. But let's book in for 10 years time and see where we get to, and in terms of what the strides that you will make in terms of working out more about hoarding and the links with other things. And that's, I suppose, what I've taken mainly from this, is that I spend my time saying, oh, you've got this, you've got that, or that. But actually, it's the grey, is what you say. And I think that is probably one of the most fascinating things. Actually, it's good to know, but actually it sort of makes it harder, I suppose, doesn't it, to treat people, because you're on a spectrum for lots of things and not necessarily one thing. That's the difficulty. But
it's difficult to treat, it's difficult to research, it's difficult, but that's life. Life is complicated. And when we do research, we were sort of putting up a picture, a mirror what we understand from the subjective experience of people and how they live their lives. And yeah, it's complicated.
Yeah,
no doubt about
it's complicated, but knowledge is power. Dr. Sharon Morein, thank you very much. It's really good to talk to you. Good luck with your research, and appreciate your time, because I know you're very busy. So thank you very much indeed. I'm going to let Sharon go now, and I'm going to just sign off and say thank you very much to Made of Millions and Orchard for hosting this webinar. Hopefully you've got lots out of it, and you'll be able to view this on YouTube on from the Made of Millions website. So thank you all very much indeed for watching. Goodbye.